Hi, everybody. Thanks for joining. Today's topic is Radiation 101 with Dr. Gupta. So, the description is in this presentation, Dr. Gupta will give an overview of radiation therapy and then dive into the different types of radiation treatments utilized for gynecologic cancers. I will also discuss the common side effects of radiation. Dr. Gupta is an associate professor in the Department of Radiation Oncology at Mount Sinai Health System. He specializes in the treatment of gynecologic malignancies as well as and he's a part of the gynecologic oncology team for the past 15 years. Dr. Gupta has become a well-respected thought leader in radiation oncology through his great accomplishments in the field, and he has over 70, excuse me, 70 publications in major oncology journals. He's presented his work at the international conferences. Dr. Gupta is also a major oncology excuse me, I am butchering everything.
We can skip the intro. It's okay. You're
Dr. Gupta's
struggling.
great is our synopsis of this, and his description is in everything I sent today. I
Okay.
apologize, Dr. Gupta, the floor is yours while I
No
cough
problem.
on mute. I'm so sorry.
Hi. Good afternoon. Good to see some familiar faces on this call. As Jillian said, I've been here at Mount Sinai for over 15 years now, treating gynecologic cancers. And I work closely with the gynecologic oncologist, the medical oncologist, pathologist, radiologist, all together as a multidisciplinary team to help ensure the best outcomes for our patients. And then we are part of a national cooperative group trials that we do with the major gynecologic society to help improve outcomes even further. I'm going to speak today about kind of the overview of gynecologic oncology and especially the radiation uses for GYN cancers. Let me start sharing my slides. Okay, can you guys see my slides?
Yes.
Great, excellent. Okay, so I just want to go over the anatomy of the female gynecologic organs that we'll be talking about, and it helps us to understand the staging of the cancers and how we treat them. So in the middle here, we have the uterus. The wall of the uterus is made up of muscle, and this is the muscles that contract when women have children and they're trying to squeeze the baby out. This whole muscle layer contracts. So this is all muscle. Cancers of the uterus usually start on this inner lining of the uterus called the endometrium. So you'll hear us use the terms endometrial and uterine cancers kind of interchangeably because the cancers all start on this inner lining. They usually don't start in the muscle. If they start in the muscle, that's a rare type of uterine cancer called a sarcoma. But generally, when we're talking about cancers of the uterus, we're talking about endometrial cancers. That's this white line right here that's lining the entire surface of the inner surface of the uterus. At the bottom of the uterus is the cervix. So even though the uterus and cervix look like this part of the same structure, embryologically they are different, and we actually treat these cancers differently. I'm going to be primarily talking about endometrial cancer and cervix cancer in this lecture. The vagina is below the cervix. The fallopian tubes and the ovaries are next to the uterus. And there's this tissue here called a parametrium, which means next to the uterus in Latin. So it's just this tissue that lines the sides of the uterus and the cervix, and it really helps suspend these organs in the pelvis. So these ligaments are then attached to like the pelvic bones, and that's what keeps the uterus kind of held up inside the female pelvis. This is an important structure because if this is involved with cancer, either an endometrial cancer that spreads sideways or a cervix cancer that spreads sideways, we change the management based on that. So you'll hear me use this term, the parametrium, throughout my talk. I'm not going to really discuss fallopian tube or ovary cancer management, mostly because we don't use radiation in those cancers. Those are cancers usually treated with surgery and chemo only and not radiation. And vaginal cancers are so rare that we don't really need to discuss them in this setting. The other things to know about cancers of the uterus and cervix is that they drain to what's called lymph nodes. Lymph nodes are things that help us fight infections. We have thousands of them throughout our body, from essentially our neck down to our legs, and they're scattered throughout our body. And if a cancer gets in those lymph nodes, we have to change our treatment, and they're very important to know for prognostic purposes and to help us guide therapy. So these are often evaluated either surgically, meaning they're removed and looked at under a microscope, or we use scans to help determine if these lymph nodes can be seen. If they are involved with cancer, they're usually big. And so that's when we are suspicious of them being involved with cancers, when they're big. And you see that these pelvic lymph nodes, they sit next to and above the uterus. This is a side view of the pelvis. So here's the uterus in a side view with the cervix here, and this is the vaginal canal. Just in front of the vaginal canal is the urethra and the bladder. And you see how the uterus actually kind of flops over and rests on the bladder. And then the rectum sits right behind the uterus and the cervix. And oftentimes when we treat with radiation, the bladder and the rectum are kind of innocent bystanders because they're so close to the cervix and uterus that they often receive a little bit of radiation dose, which can cause the bladder to fire more frequently and be irritated. And same thing with the rectum, can fire more frequently and cause diarrhea. Okay, so I just wanted to make sure everyone's familiar with the anatomy, because that really helps us talk more in depth about these cancers. So women who have cancers of the uterus, they almost always have hysterectomies to start. And this is what things look like after the hysterectomy is done. You see now the vagina just ends, dead ends. There's no uterus or cervix above it. And we just have what's called a vaginal cuff. That is the end of the vagina. And it's stitched closed when the uterus and cervix are removed. And it takes it and heals over a couple of weeks until it just becomes like a dead end. And again, very close to the bladder and the rectum. Okay. I just briefly wanted to go through the history of cancer treatment. Sometimes when women come to see us to talk about radiation treatment, it sounds a little bit crazy, and people are like, oh my gosh, this sounds experimental. How long have you been doing this radiation stuff? So I just wanted to go through a really quick timeline. So there are records from the Egyptians doing surgery for cancer over 5,000 years ago. They actually were doing mastectomies for breast cancer in Egypt many, many years ago. And that's kind of the earliest signs, or earliest treatments for cancer. It wasn't until many, many years later that William Röntgen discovered X-rays in 1895. This picture here is actually the first X-ray ever taken. It was his wife's hand with a ring on her finger. She was the first kind of test case, and that was the first X-ray ever taken. The following year, Henri Becquerel discovered radioactivity in uranium. Marie Curie discovered polonium and radium. These are naturally occurring radioactive substances, and they found that you could actually treat with radiation. Unfortunately, in 1934, Marie Curie died of anemia because she was handling radiation for many years, and we didn't know what the side effects of radiation were. But so she died of radiation toxicity because she was around it too much. In 1896, a medical student named Emile Grube opened the first radiation treatment facility for cancer in Chicago. I don't think medical students can open cancer centers these days, but that was allowed in 1896. That was the first kind of documented radiation treatment for cancer facility in the country. And so these were his hands, and you see they are kind of mottled and blistered. He actually required an amputation because, again, he was handling radiation, not knowing the side effects. I now know I can't hold radiation because of people like them. We can't be around it directly. But it wasn't until the 1940s that nitrogen musters were used for lymphoma. This was the first chemotherapy agent. So you can see that radiation was used about 50 years before chemotherapy was used. And so almost twice as long. And so I don't think a lot of people realize this, that radiation has a longer track record than chemotherapy. Okay. So in general, there are 3 cancer treatment options. Surgery removes all or some of the tumor. And typically the goal of surgery is to cure a cancer. And it's rare that someone has widely metastatic cancer and that that they're incurable, and it's rare that those patients would have a surgery in the non-curative setting. Once in a while it's done, but typically surgery is with the intention of curing somebody. Radiation treatment, the goal of it is to kill the cancer cells. It doesn't kill, the organ is still there. Some people say, what happens to my cervix? If you irradiate it, will it be gone or is it still there? The organ stays intact, which is different than surgery, right? If you have your cervix removed, it's gone, it's outside of your body. So radiation keeps the organ there, but just kills the cancer cells within that organ. Radiation can be used either to cure patients or to palliate. Palliate means make them feel better. Maybe the tumor is causing pain, maybe the tumor is bleeding. So we can use radiation to kind of palliate a tumor in situations that are not curative. We can still offer them some benefit. We rarely do palliative surgeries, but surgery is there for cure. Chemotherapy, similar to radiation, kills the tumor cells. It does not get rid of the organ itself. The organ is still there, just kills the cancer within the organ. It's typically used with surgery and or radiation to cure cancers. It's rare that we use chemotherapy by itself to cure a cancer. The exceptions are leukemia and lymphoma. So this is also something that patients are shocked to hear. You will not use chemotherapy to just cure a cancer by itself. You need surgery or radiation along with chemo to kill something completely. However, if someone has metastatic cancer, meaning it has spread to other organs, chemotherapy generally is the primary treatment. I'm going to lump immunotherapy and biologic therapy into this kind of chemotherapy category. Okay. So in general, there are different types of radiation treatment that we can offer. By far, the most common kind of radiation treatment used to treat patients in general, not just gynecologic cancers, but cancers all over the body, is external beam radiation. It's done with a machine called the linear accelerator. Here is a picture of one. You can see this machine kind of rotates around the patient. Patient's laying down. There are radiation therapists that help set patients up every day. We have these lasers, you see these red and green lights here that help with alignment. So the patients lay down on the table and this machine moves around the patient. Typically, patients are given daily, Monday through Friday, and on average, treatments last about 5 weeks. In gynecologic cancers, the targets can be the pelvic lymph nodes. It can be the perimetrium. Remember, that's that tissue that helps keep the uterus and cervix suspended in the pelvis. And the cervix and the uterus, if they're intact, these sometimes are removed during surgery before radiation. If they are not there, obviously we're not targeting them. And then we also will target the upper vagina and potentially the vaginal cuff if the cervix and uterus have been removed. Okay. Another type of radiation treatment is called brachytherapy. Brachy means next to, meaning we put the radiation next to the tumor. So rather than having a machine that delivers from outside the body, we put some type of catheter into the body to deliver radiation more closely. So there's something called intracavitary. That means we insert the device into a cavity that's already there. The most common kind for gynecologic cancers is this vaginal cylinder that goes into the vagina. This rounded edge would go up against the vaginal cuff that we talked about. That would be right here. So the cylinder would be placed right up against this vaginal cuff. So that's intracavitary because it's a pre-existing cavity. Interstitial is when we use needles that pierce through the tissue. You can see this device here has some needles sticking through, and that's generally for more bigger tumors that require a more intense treatment. The targets of brachytherapy can be the cervix, the uterus, the vagina, the perimetrium, again, depending on where the cancer is and whether or not the patient's had surgery. In general, almost all patients require a simulation. A simulation, we also call it kind of a mapping session, which is basically a CAT scan that we do. During the CAT scan, we make an immobilization device. This is one that we particularly use for breast cancer, but we have hip immobilizers that will help keep the hips stable. And we use these devices for the planning session, and then we use that same exact device for each of the treatments to ensure that the hips are in the same position each day. With this CAT scan, what we do is we delineate the tumor and the nearby organs. So we go on each slice of the CAT scan, we show them where the cervix is, where the rectum is, where the bladder is, where the bones are. And by doing this process, we are able to tell the computer where is the cancer and where are the areas that we're trying to avoid, such as the bladder and rectum. So this is can be a fairly time-consuming process. So it takes us maybe a couple hours to do this. This is basically my operating room where I decide where I'm going to aim the radiation, and it's where the bulk of our work is done. So the patients get a CAT scan, they're into our department for about an hour, then they go home. And after they go home, this is when I'm doing my radiation treatment planning. This is, the pelvis, here is the right hip, here is the left hip. This green structure here is the rectum. This orange structure here could be the bladder or maybe the vagina. And these white areas here are just the other pelvic bones. This here, these are just muscles. This is the gluteus muscles. These are the thigh muscles. And so we want to really just aim the radiation in the middle of all this, but avoid radiation to these other structures. Once I delineate all these structures, we have dosimetrists and physicists. These are the radiation planners, and they are there to kind of use the computer software to help maximize dose to the actual tumor and minimize dose to the areas you're trying to avoid. Okay. So it's for you guys to understand the patient flow through our clinic. So patients are diagnosed with cancer, usually by a surgeon. There's some type of biopsy that's done. And then once cancer comes back on that biopsy, we get some staging studies. These can be lab tests. They can be imaging studies. It includes CAT scans, MRI scans, PET scans. And depending on the stage of the cancer and the type of cancer, that determines what imaging studies are used. And then if appropriate, the patient is sent to us for a consultation. And then if we decide that radiation is indicated, then we will perform a simulation about a week later. And the reason there's a delay is mostly due to insurance clearance. We need to make sure that insurance is going to clear the treatment that we're recommending. Because if they don't, then obviously patients get a big bill, and we don't want that to happen. So this is getting harder and harder to obtain these insurance approvals. Insurance companies have been increasingly difficult to work with. You've probably read about several of the insurance battles Mount Sinai and other local institutions have had with insurance companies over the past couple of years. It's been very frustrating for everyone involved, including patients, I'm sure. It takes me about one week or so for the radiation planning. So after simulation, we usually start radiation about a week later, depending on the complexity of the situation and the urgency. And then we actually give the radiation treatment, which can be anywhere from 3 to 8 weeks for gynecologic cancers. I meet with my patients routinely during this radiation treatment, usually once a week, but more if necessary. And then I typically follow my patients for about 5 years after finishing treatment. The goals of the follow-up care are to assess for cancer recurrence. Most gynecologic cancers, if they come back, they come back within the first 2 years. Those first 2 or 3 years are the most critical. So we tend to, between me, the surgeons, and the chemotherapy doctors tend to kind of follow patients every 3 months or so for the first couple of years. Once we get beyond that 2 or 3 year mark, we can start spacing out those follow-up visits. The other goal of follow-up care is not only to look for tumor recurrence, but it's also to ensure that you're not developing late side effects from radiation treatment. And I'll get to those side effects later on in the talk.
Oh, yeah.
Okay. Before I go into talking about the specifics of endometrial cancer and cervix cancer, are there any kind of general questions about radiation therapy or anything I've just covered so far? Looking in the chat, there's one question. Okay, there's one. Yep, so I will get to the radiation proctitis hopefully before we get to before this person has to leave. Okay. So endometrial cancer, I mentioned that there's a couple of different radiation options that we have. External beam radiation typically targets the vaginal cuff. So almost everyone with endometrial cancer has a hysterectomy first. So the uterus and the cervix are gone. Therefore, they are not targets of the radiation. The vaginal cuff is the blind end of the vagina. The perimetrium is typically still intact after hysterectomy for endometrial cancer, and then the pelvic lymph nodes are there. This is typically a daily treatment Monday through Friday for 5 weeks. Brachytherapy is another option. It's for endometrial cancer. This is a cylinder that we would use for that. This treats the vaginal cuff only. It's the most common site of recurrence in stage 1 cancer. There are various treatment schedules that are available. It's typically 3 to 6 treatments over 3 weeks. So you'll see that the cylinder and the external beam both treat the vaginal cuff, but the external beam also treats the perimetrium and pelvic lymph nodes. So depending on what stage the cancer is and what type of cancer is in the endometrium, we may not need to target everything. So maybe just the vaginal cuff cylinder is all we need. This is a hollow tube. Once after we insert this into the patient, there's a tiny radiation source that goes through this tube. It takes 5 or 10 minutes for it to go to the top and out. Okay, it's as I said, it takes 5 to 10 minutes. The patients don't feel the radiation in either of these treatments. This is just like a cold plastic tube the patients feel inserted, but there's no pain or burning during either of these treatments. External beam, as I mentioned, there are lymph nodes that we target, and the lymph nodes are, the uterus would be right here, and so the lymph nodes lie to the side and above the uterus and cervix, and these are just the lymph node groups that we would treat in the pelvis. And so it's a much more generous, this blue area here is kind of the radiation treatment that we would design to treat all of those lymph nodes, in addition to the uterus, cervix, or the vaginal cuff, depending on if the patient's had surgery or not. Okay. Just showing the radiation dose. When we treat with external beam, we treat kind of this red square area. Again, this is the right hip, this is the left hip, this is the rectum back here, the vagina, cervix, and uterus would be in the middle, and this is bowel right here. So you see this a very generous area that we treat with external beam radiation. And even though the hips and these muscles out here aren't part of the targets, they end up getting about half of the radiation dose, and it's just usually not relevant. Patients usually don't develop any side effects from this low dose radiation out here. It's just one of those unintentional consequences of radiation. This is a view from the front. This is again the right hip. This is the left hip. This is a patient standing and looking straight at them. This is the uterus here. And so this whole area is getting a generous area of radiation. When we use brachytherapy, you see this is the cylinder inside the vagina, and this is the prescription dose, just a very small red line compared to this area that extends way beyond it. This blue line is kind of half of the dose, and you see in this external beam, it's a much more generous area versus brachytherapy is a much smaller area that's getting the dose. Okay, so if someone only has risk in the vagina, brachytherapy is a great option. However, if they have a more aggressive or widespread cancer, we may need to use external beam. So patients with endometrial cancer can have either external beam, they can have brachytherapy, and in some situations, they may need both. Okay. So the staging for endometrial cancer, stage 1, I don't want to go too much into the staging, but stage 1 is essentially limited to the uterus itself. Stage 1A is when it's less than half of the thickness of the uterine wall. Again, this is a muscle layer of muscle. And 1B is when it's beyond 50%. So this is a big cutoff for us, at 50% invasion through this muscle wall. Stage 2 is when it involves the cervix. Stage 3 is when it goes outside of the uterus, but is still within the pelvis. So maybe it's involving this outer lining of the uterus called the serosa, or the fallopian tubes or ovaries. Maybe it involves the perimetria, which again is this tissue on the side, or it goes down to the vagina. And then 3C is when it involves lymph nodes. Stage 4 can be that the tumor is extending directly into the bladder or rectum, or it can be when it's gone through the blood to go to the lungs or bones, and that's when it's metastatic. I will let you know that the staging system was updated in 2023. It has become much, much more complicated. It's almost become impractical to use, and a lot of people haven't switched to it. We just kind of use both of them at Mount Sinai to help us kind of understand the patient better, but we pretty much still base treatment based on this old staging system. So we actually kind of use both in our notes when we discuss patients and in our meetings. Okay. So for endometrial cancer treatment, the first step, as I mentioned before, is surgery. Almost everyone with endometrial cancer will have a hysterectomy to begin with. And then whether or not they need treatment after surgery depends on several risk factors, including the stages that I just went through. We look at the actual myometrial invasion. Even though 50% is the big cutoff, and that's in the staging system, we want to know, is it 51% or is it 98%? Because those would kind of have different connotations for us. So we look at the absolute value of this myometrial invasion. Lymphovascular invasion is a fancy term. It essentially means the highways that take the tumor from the uterus to the lymph nodes that may lay out here. So there are kind of highways within the uterus that take that tumor from the uterus to the lymph nodes. So we look within the uterus, are these channels involved with tumor? Because even though the lymph nodes may not have tumor, if they're in those highways, it suggests that this tumor is a little bit aggressive and may be on its way to the lymph node. So that's what lymphovascular invasion means. Histology is the type of cancer that we see in the uterus. There are different kinds. The most common kind is called endometrioid adenocarcinoma, but there are more aggressive types such as papillary serous carcinoma and clear cell carcinoma. We look at the grade of the cancer. The grade, it's 1, 2, or 3. Grade 1 means it's slowly growing. Grade 3 means it's quickly growing and tends to spread more rapidly. So we treat those grade 3 tumors a little bit more aggressively than we treat grade 1. We also look at the age of the patient. As patients age, their cancers actually become more aggressive. So an 80-year-old woman with endometrial cancer has a more aggressive cancer than a 50-year-old woman does. We don't know why, but study after study shows that stage for stage, we know that older women have more aggressive cancers than younger women. So we treat older women actually more aggressively, which is counterintuitive to a lot of other cancers or to believe. And breast cancer, the younger you are with breast cancer, the more aggressive it is, but the opposite is true for endometrial cancer. And then based on all these factors, we put patients into different risk groups. There's a low risk group. These are the earliest stage patients where the cancer is really limited to the endometrial lining and doesn't involve the muscle at all. Grade 1 and grade 2. Luckily, this is the most common risk group. They have a less than 5% risk of recurrence after surgery alone, and we don't routinely give these patients any treatment after surgery. Okay, so their risk is so low of the cancer coming back that we don't need to treat them anymore after surgery. Intermediate risk group patients, these patients have a 10 to 25% risk of recurrence after surgery alone. We may recommend radiation for these patients depending on their exact features, and radiation reduces the risk of recurrence. I mentioned before that the vaginal cuff is the most likely site of recurrence for these kind of earlier stage patients. Radiation after surgery has been shown to improve the risk of recurrence down to about 3 to 15%, down from 10 to 25. And radiation, even though it improves the risk recurrence rate, it does not improve survival. So we will often have these balanced discussions with patients to talk about the benefits of radiation and the risks to decide if radiation is the best treatment for them. High-risk patients, these are patients who have cervix invasion that we see on exam. Patients have stage 3 or stage 4 cancers, or any patients with papillary serous or clear cell, because these patients have these histologies are much more aggressive. Any stage is considered to be high risk with these histologies. These patients have more than 50% risk of recurrence after surgery alone, so we almost always recommend further treatment beyond surgery for these patients. The recurrence may be in the lungs or the bones or possibly somewhere in the pelvis. Because their risk of recurrence outside of the pelvis is so high, these patients will almost all get chemotherapy, possibly with or without radiation. Chemo has been shown to improve survival, and so we definitely recommend chemotherapy for almost everyone with high-risk disease. Immunotherapy has been shown to improve outcomes with chemotherapy versus chemo alone, so we're trending towards that. Radiation reduces the risk of the cancer coming back in the pelvis, and it can be given during or after chemotherapy. So endometrial cancer, the conclusions is that surgery is the mainstay of treatment and is the first step. Post-operative treatment depends on the risk factors. I mentioned several of them earlier. For early stage patients, we look at the age, the grade, the amount of muscle invasion. The myometrium is the muscle wall of the uterus, and then we look at lymphovascular invasion, which is are those highways I mentioned. For low-risk patients, we do not give any post-operative treatment. In intermediate risk patients, we discussed that post-operative radiation improves the recurrence rate in the vagina and pelvis, but it does not improve survival. And we typically recommend vaginal cuff brachytherapy for patients with intermediate risk disease. High-risk patients, we typically recommend chemo, possibly with radiation. And then we're adding immunotherapy more and more to these kind of high-risk patients in addition to the chemo. And then radiation reduces the risk of recurrence in the vagina and lymph nodes in addition to the chemo. The type of radiation used in high risk, some patients we give external beam, some patients we give brachytherapy, some patients we give both. Again, it just depends on the situation, and that's more of a one-on-one discussion with patients and their doctors. I just wanted to mention briefly, because I think someone had a question about radiation proctitis. So I'm going to get into more detail about the side effects later, but I just wanted to mention, so because the rectum is so close to the vagina and the vaginal cuff is a target for radiation, patients can develop radiation proctitis. That means inflammation of the rectum from radiation. That can cause diarrhea. It can cause bleeding. Those are kind of the typical manifestations. Sometimes people can have pain with bowel movements. This is usually a short-term thing and usually goes away about 2 or 3 weeks after radiation is done. We generally recommend over-the-counter diarrhea medication if the diarrhea is the only thing that they have. If there is bleeding, we may recommend some type of steroid suppository to help calm down the inflammation from that. It's rare that someone needs anything beyond that. If they do, we have them see a gastroenterologist where they do a colonoscopy, and they could potentially use a laser to cauterize any bleeding blood vessels. And so that's generally the extent of it. It's very rare that even that needs to happen, but usually it's just managed with Imodium, the over-the-counter diarrhea medication, and once in a while we need to give a steroid suppository for pain and bleeding. I hope that answers the question for whoever asked it. Okay. Again, we'll get more into the side effects later, but I wanted to mention that because that person said they had to leave at 12:40. Okay. Any questions about endometrial cancer before I go to cervix cancer? I don't see anything in the chat. Okay. So cervix cancer. I'm going to describe the radiation techniques that are available for cervix cancer. There's external beam, which can treat the cervix, the uterus, the perimetrium, and pelvic lymph nodes. Cervix cancer is managed differently than endometrial cancer. I mentioned that in endometrial cancer, we almost always start with surgery. Cervix cancer, depending on how large the tumor is to begin with, we may not start with surgery to begin with. We may start with radiation instead. So it's a different treatment. And so we may be treating the intact cervix and uterus. And again, the perimetrium is the tissue next to the uterus, and then the pelvic lymph nodes may be at risk. So it's, again, a daily treatment Monday through Friday for 5 weeks. Brachytherapy, we use a different device that's called either a tandem and ring or a tandem and ovoid. This targets the cervix and the uterus. It's generally a weekly treatment for 3 to 5 weeks. We insert the device into the vagina through the cervix and into the uterus. And you see here is where the tumor is, and this device kind of surrounds the cervix with radiation dose internally. Generally, we do both of these for cervix cancer. We don't do one or the other. If someone has a big enough tumor at the beginning, we do both of them, not just one. That's different than endometrial cancer, where sometimes we just do brachytherapy for endometrial cancer. We would not do that for cervix cancer. And that's because if you have a cervix cancer that's big enough that surgery is not adequate, that means it's so big that the lymph nodes are at risk. So we need to treat with external beam to treat the lymph nodes, but then we also need to use brachytherapy to really increase the dose to the cervix to really kill off this cancer. We generally don't like to use a really high dose of external radiation to treat cervix cancers because of the bladder and the rectum being so close. We then increase the risk of side effects to the bladder and rectum by using such a high dose with external beam. The internal radiation brachytherapy allows us to give a much higher dose safely. So we generally use that to help us get to that extra dose we need to treat those tumors. Okay. There are several different kinds of applicators that we use for cervix cancer. This is the tandem and ovoid. This is a tandem and ring. These are the two most common things. I just have some pictures of other ones just so you see them. These are all hollow tubes. We attach the hollow tube to this radiation machine. The radiation kind of lives in, it's like a pellet that's like the size of a pencil tip. It lives inside this machine. And when it's time for treatment, the pellet gets forced through this machine through a wire. And then the wire is attached to these devices, and the radiation goes through this slowly over about 10 minutes. Okay. So I'm just going to go through the procedure a little bit so everyone's a little bit familiar with this. So the tandem and ring or the tandem and ovoid procedure, we often do in some kind of procedure room. I do it here in an operating room that we have here. Sometimes it's done in the radiation clinic. We usually use some kind of sedation, whether the patients have general sedation or moderate sedation. And in some rare situations, I do it, which is while they're totally awake, but I give the patients pain medication to help them through this. Patients are placed on their backs with their legs in stirrups. We do an exam to assess how big the tumor is and if it's spread into the vagina. We put a Foley catheter into the bladder. Patients generally are in our clinic for about 6 hours that day for this procedure, and they can't get up to pee. So a catheter is placed in the bladder to help drain the urine, and then we clean the area. We examine the cervix and the opening of the cervix with the speculum. If the tumor is bigger than 4 cm, brachytherapy may not be adequate. Brachytherapy is most effective when the tumor is less than 4 cm. We may need to give additional external beam radiation to shrink the tumor if it's more than 4 centimeters, or if they've completely finished external beam, we may need to give those needle brachytherapy. It's extremely rare that we need to do this, but since it usually shrinks. The uterus is sounded, which means we put a tube into the uterus to see how long the uterus is, and that lets us know how long the tandem we need to insert. The tandem is this long rod that goes through the cervix and into the uterus. We don't want to poke through the uterus, so we need to know how long the uterus is. So we use an instrument called a sound that helps us determine how long the uterus is. And then the surgeon, the gynecologic, usually places a Smith sleeve, which is this white plastic or silicone tube that we insert into the cervix. Sometimes this opening in the cervix is covered with tumor, and it is hard to find this opening. So I go to the operating room with the surgeon, and we look for this opening in the cervix, and we stitch this device in place so that it's much easier for me to do the second, third, and fourth procedures without the surgeon present. So I'm not a gynecologist. I've done hundreds of GYN exams, but I'm not a gynecologist, and it's a little bit harder for me to find this opening than it is for the gynecologist. So they kind of cannulate the cervical opening by placing this tube in, and then we place the tandem through this tube and into the cervix and uterus. Okay, so the tandem is inserted through the cervix opening via this Smith sleeve. The ring or the ovoids are placed right next to the cervix and secured to the tandem. So this is an example of a ring. It looks like a little donut that's placed at the base of the cervix. Then we insert a rectal retractor. The rectal retractor is this rectangular plate that goes into the vagina and merely just creates space between these radiation applicators and the rectum. And then we put vaginal packing, which is this gauze that we put into the vagina to push the bladder away, again, to protect the bladder from the radiation. Okay. We use a radiation source called iridium that's stored in this machine, and then the machine, like I said, pushes it through on a wire, and that goes into these tubes, and it takes about 10 minutes for the treatment. And the radiation moves slowly along these tubes, and it treats the upper vagina, the cervix, and the lower uterus. Okay. So staging for cervix cancer is pretty complicated. Just stage 1A is microscopic. These patients are all getting surgery. 1B is when you can actually see it with the naked eye. Some of these patients get surgery, but once it gets to bigger, like more than 4 centimeters, these patients will almost all get radiation with chemo. Stage 2 is when it's into either the upper vagina or into the perimetrium. Again, that's the tissue on the sides of the cervix. Stage 3 is when it's in the lower vagina against the muscles or the bones of the pelvis, or it causes blockage of the ureter, and the
Just a second.
blockage of the ureter causes swelling of the kidney or the kidney not to function properly. Stage 3C is when you have pelvic nodes or periaortic nodes involved. And then stage 4 is just like it is for endometrial cancer. So the treatment by stage, I mentioned that these earlier stage and smaller tumors, we generally recommend surgery. We may need to give post-operative radiation depending on the findings at surgery. When we have bigger tumors, such as bigger than 4 cm, or if there's lymph node involved that's seen on scans, we'll give external beam and brachy. It's typically given with cisplatin. The goal is to complete all of the treatment, the external beam, which is 5 weeks, and then there's 3 or 4 weeks of brachytherapy. The goal is to finish everything within 7 or 8 weeks. Prolonging the treatments beyond that can increase the failure rate by 1% a day. This is striking. So if someone has an extra week of treatment, that means that their cure rate goes down by 7% or so. And multiple studies have shown this, that timing is of extreme importance. We need to get everything done fairly quickly within 2 months. This is not true for endometrial cancer. This is true for cervix cancer. So to conclude, for cervix cancer, surgery is preferred for the earlier stage patients. Post-operative radiation may be given depending on the findings at surgery. If they need post-operative radiation, it's generally only external beam. We don't generally give brachytherapy. We can't use that tandem and ring after surgery because that tandem goes through the cervix and into the uterus. But if someone has had their cervix and uterus removed, we can't place a tandem in there. So we generally just do external beam if they need post-operative radiation, but we don't see this all that often in our clinic. We use concurrent chemotherapy and radiation for larger tumors or if the tumors involve lymph nodes. This requires external beam and brachytherapy because we need to get to high doses. We can't give all of the high dose with external beam because that would cause damage to the bladder and rectum. So we use brachytherapy that can really focus the radiation on just the cervix and uterus. It gives much less dose to the bladder and rectum. We're adding immunotherapy more and more to this treatment as well. Okay. So now I wanted to go through The side effects of radiation. This is true for both cervix and endometrial cancers. It's really true for anyone getting pelvic radiation. So someone who has rectal cancer would also potentially have some of these side effects. So acute side effects, these are side effects that happen during the radiation and perhaps potentially shortly after, meaning within a month or so. Chronic side effects are side effects that develop months or maybe even years after radiation is given. So for external beam, acute side effects patients may have are diarrhea and rectal bleeding. We see diarrhea fairly commonly, but we rarely see rectal bleeding. Patients have urine frequency, which means they go to the bathroom often. Urgency is it's hard to hold it. So when you gotta go, you gotta go. So we see this fairly frequently as well. Dysuria means pain with urination. Hematuria means blood in the urine. Less common, but we do see these from time to time. Fatigue, skin desquamation, that's dryness and peeling and darkening of the skin that can happen in the lower pelvis. Again, these side effects usually go away about 2 weeks or so after treatment is done. Chronic or long-term side effects of radiation. Sometimes patients can have kind of permanent irritation of the rectum that causes diarrhea and rectal bleeding in the long term. There are a few options for this. As I mentioned, we can sometimes give enemas with steroid enemas. Sometimes we can send the patients to gastroenterology where they will use a laser to kind of stop the bleeding. And there are even some more intensive treatments beyond that if need be, but it's very rare that we need to do that. They can have urine frequency and urgency in the long term, urine and fecal incontinence, which means the urine leaks or the stool leaks. Very rare. I often, the most of the time that this happens is usually after a hysterectomy. I feel like the uterus provides some support to the bladder, and when the uterus has been removed, I find that urine incontinence is more common. So I blame the surgeons, but I'm sure they blame me. So it's a back and forth. Bowel obstruction or perforation. So sometimes patients can get scarring in the pelvis on the outside lining of the intestines. And occasionally that scarring becomes so severe that it actually blocks the intestines from working and they're constipated and it can't actually pass gas or stool. And that can actually cause the intestines to almost kind of perforate or break open because of that. It's extremely rare that this happens. Usually it happens if the patient has had multiple surgeries before, like they had their appendix moved, then they had their gallbladders removed. That causes scarring. And then they have a hysterectomy, that causes more scarring. And then they have radiation, and that causes more scarring. So then they have like all these procedures that potentially cause more and more scarring. That's the situation where we may see this versus if someone's having just a hysterectomy and they've never had any other surgeries in the pelvis before. It's rare that we see that. Leg edema or swelling, that can happen from radiation. Typically, it's after if they've had surgery. Not seen very often, but it can happen. Again, usually it happens if patients have had multiple pelvic procedures. Femoral neck or pelvic bone fractures, this can occur. It's often patients don't have symptoms. They're getting scans to kind of follow up on their cancer. So a year or two after they've had radiation, they may have a scan to see if their cancers are come back. It says there's no signs of cancer, but there's a new bone fracture. They call them insufficiency fractures. These are increased in patients who are smokers, increased if patients have osteopenia or osteoporosis, but it can also happen without those issues. Just radiation itself can cause bone fractures. It's one of these things that unfortunately there's not current treatments. If patients have pain, we usually recommend physical therapy and medication, kind of pain medication for it. Okay. From brachytherapy, whether it's the cylinder treatment or the tandem and ovoid treatments, acute side effects, it can be diarrhea, can be dysuria, again, pain with urination, uterine perforation. I mentioned those tandem tubes can poke through the uterus if they're not placed properly. And unfortunately, that is one of the things that happens. Anyone who does tandem and ovoids with any regularity, I've caused this with the surgeons and all throughout the country. I talk to colleagues, and it happens once in a while. It doesn't happen often, but it can happen. Vaginal laceration, that's tearing of the vaginal mucosa. That can happen when we insert the rings. It doesn't happen with cylinders. I've never had it happen with a cylinder, but I have had it happen with when I insert the rings because they're bulkier and it just stretches the vagina too much and that causes tearing. Chronic side effects to brachytherapy, vaginal dryness, fibrosis, shortening. This is why we recommend patients use dilators. Anyone who gets brachytherapy for GYN cancers in our department gets a dilator to prevent the fibrosis and shortening. Vaginal dryness can be treated with estrogen creams. This can, all these side effects here can cause difficulty with pelvic exams in the future. It can cause difficulty with sexual function in the future. So we try to prevent that using the dilator. Urethra stricture, that's scarring inside the urethra. That's when women say it's really hard for me to urinate. It feels like something's blocked, and that can be a cause caused by radiation causes scarring, resulting in scarring. It's really rare that that happens, but it's possible. If it happens, we will have you see a urologist who kind of clear out some of that scarring with a surgical procedure. Fistula, this is an abnormal opening between the vagina and the bladder, or the vagina and the rectum, which would result in either stool or urine leaking through the vagina. Again, extremely rare, but it does happen in about 1% of patients that go through these procedures. Okay, that's the end of my talk. I'm going to take questions. It looks like there's some in the chat. For general my chart or pre-scan questions for normal maintenance procedures, should brachytherapy be mentioned? So if someone's getting a bone scan, so brachytherapy doesn't affect the bones at all because the radiation is so focused on the vagina. It usually doesn't have any impact on the bones. So I wouldn't expect anyone to have any fractures or any sequela to the bones from brachytherapy by itself. External beam, I think it would be worthwhile mentioning to the provider who's ordering these scans to let them know, because sometimes they see fractures and they say, oh no, you have a new fracture. You have to see like an orthopedic surgeon and whatnot. But as long as everyone knows that you've had radiation, I'm not saying you shouldn't see the orthopedic surgeon if there's a fracture there. I'm just saying it's good that everyone knows that information. But brachytherapy, there's no risk to the bones from that, so it's not necessary. Another person asked that 2023 reference to new changes to staging is important since the guidelines subsequent treatment options. Yep. So so the main change in 2023 is that it is incorporating molecular markers into the staging system. They're looking at mutations in some of the genes. It's fairly complicated, so I don't want to go through it in detail, but they look at like P53. If someone has a P53 mutation, their cancers behave more aggressively regardless of their stage. So if someone has a P53 mutation in their tumor, that automatically puts them at a higher stage of cancer, regardless of what the myometrial invasion is, and things like that. So we're really trying to personalize the prognosis and the treatments for endometrial cancer much more. So they look at all these mutations and molecular markers to determine how that's going to affect someone's prognosis and treatment. Other thing is POL-E mutation. If someone has a POL-E mutation, their cancers actually behave much better. And so we may need, if someone's borderline needing a therapy, we may say, oh, well, there's a POL-E mutation. Maybe we can ease up on the treatment. We don't need to be so aggressive. We're actually doing national studies. This is part of the national studies I was talking about, where people are saying maybe we don't need to be so aggressive. Someone has a POL-E mutation. So these are in the staging system now and can help us guide treatment slightly. But it's not really the mainstay. In general, throughout the country, I wouldn't say someone's drastically changing their treatment now because of P53 or these POL-E mutations. So that's why we still rely kind of on the older staging system because the data is much more robust for that older staging system than this newer staging system. I'm not saying we won't get there, and I'm saying some institutions may use the new staging system to help guide therapy, but in general, I'd say the majority of people in this country use the older staging system. There's another question about insufficiency fractures to your sacrum. Pain management strategies. So if this is a chronic pain issue, I generally recommend patients see a pain specialist. They generally try NSAIDs first to help with those insufficiency fractures. Beyond that, there are other options. Sometimes there are procedures. There's something called sacroplasty, where the interventional radiologist can inject cement into the bone to solidify the bone more. That may get rid of pain. Another option is sometimes we use oxygen treatment. This is called hyperbaric oxygen treatment that can help with healing these bone fractures. Mount Sinai doesn't offer hyperbaric oxygen, but pretty much every other major medical center in Manhattan does. So that is an option for chronic pain from these insufficiency fractures. So pain medication, you'd work your way up from kind of the over-the-counter NSAIDs to prescription NSAIDs to maybe even narcotics. If things still aren't better, like I said, we can do those sacroplasty procedures to help, and then also we can talk about hyperbaric oxygen.
Thank you.
All right. Any other questions? I think that was everything from the chat, but I'm happy to. Any other questions?
That is it. This was fantastic. Thank you so much for all of the detailed information, for sharing the everything. So thank you so much.